We'll be breaking down all major concepts covered on the exam. I mean, imagine this. An 82-year-old patient is brought into your clinic by her daughter, right? She's got this new onset urinary leakage. And your reflex, especially when you're under the time pressure of an exam, it might just be to jump straight to ordering like complex urodynamic testing.
Right, or you just quickly prescribe a bladder relaxant just to get the symptom under control so you can move on.
Exactly. But if you make that move on the MCCQE, you might just fail the question outright because the real culprit behind her incontinence is, well, it's likely hiding right in her current medication list. And fixing it requires absolutely zero invasive tests.
Yeah, which is exactly what we're getting into today.
So welcome to this deep dive designed specifically for you, the Canadian medical student gearing up for the boards. As your reviewers, our mission here is to help you feel completely comfortable navigating these high-yield yet, historically tricky presentations.
And to give you the most accurate foundation, we are drawing our clinical frameworks today directly from reliable StatPearls articles. We're focusing specifically on section SO5, renal medicine, so chronic kidney and urinary tract diseases.
Yeah, we're going to cover the pathophysiology and management of the adult leaking bladder all the way down to the pediatric refluxing kidney.
That's a lot of ground to cover. But before we get into the actual mechanisms, just a necessary disclaimer. This deep dive is for medical education purposes only. It is not medical advice.
Right.
All real-world clinical decisions should always involve a qualified healthcare provider.
Definitely. So, when we study organ systems for the boards, it's so easy to just focus on the acute dramatic failures, right? Like the massive MIs or the ruptured aorta.
Oh, absolutely. The flashy stuff.
Yeah, the flashy stuff. But today's topics, things like urinary incontinence, retention, obstruction, vesicoureteral reflux, these profoundly impact a patient's daily quality of life.
They really do. And they're heavily underreported, mostly just due to social stigma.
Right. Patients are terrified to bring them up, but they are absolutely guaranteed to show up on your exam because they're just incredibly common in primary care, which means you have to know how to look for them.
Yeah, and mastering these topics for the MCCQE, it requires moving past simply like memorizing a list of symptoms.
Yeah.
The exam is going to test whether you actually understand the underlying plumbing of the human body.
Not plumbing. I like that.
Yeah, everything we discussed today basically comes down to pressure differentials, muscle contractility, and anatomical anomalies. If you understand the physics of the bladder and the ureters, the whole diagnostic algorithm and the management steps, they just logically fall into place.
Okay, well, let's start with the sheer scale of the incontinence landscape because the global numbers are just staggering. Over 423 million people worldwide have some form of incontinence.
Wow.
And if you look at older adult women in the U.S. alone, over 60% report some degree of it.
That's huge.
It is. So going back to that 82-year-old patient from our opening scenario, before we even consider like an irreversible anatomical defect or some complex neurological issue, we have to play detective. We have to rule out the reversible causes first.
Right, the low-hanging fruit.
Exactly. I always think of this like a pilot's pre-flight checklist. You wouldn't tear apart the airplane's engine looking for a catastrophic failure if you just, forgot to turn the ignition key.
That's a great way to look at it. And a successful test taker knows that the initial primary care evaluation for incontinence, it absolutely must include the urinalysis.
Always.
Yeah, you're checking for a simple urinary tract infection, or maybe glycosuria, which would indicate poorly controlled diabetes or hematuria. And honestly, equally important is a rigorous medication reconciliation.
Right, because the MCCQE loves to test your ability to spot a simple reversible fix that's just hiding in plain sight, which actually brings us to the classic diapers mnemonic.
Ah, yes. Diapers.
Yeah, spelled with 2 P's. In an exam setting, it's really easy for our eyes to just glaze over a long list, but if we actually break down the mechanisms here, it makes perfect sense. So the D for delirium and the I for infection are fairly obvious. A confused patient or a severely inflamed bladder will obviously lead to leakage.
Sure.
Same with E for excess urine output, like you mentioned with diabetes. If a patient has undiagnosed diabetes, the osmotic diuresis is just simply overwhelming the bladder's capacity.
Right. And then the A stands for atrophic urethritis, or vaginitis, which is super crucial for the postmenopausal demographic.
How so? Like, what's the mechanism there?
Well, when estrogen levels drop, the mucosal tissues of the urethra, they thin out and they basically lose their elasticity. That mucosal seal is actually a vital component of continence. So without it, the barrier pressure drops, and that leads directly to leakage.
Okay, that makes sense. But it's the P's in the mnemonic that I think really catch students off guard. Pharmaceuticals?
Yes.
The meds? Like, if I see a patient on a diuretic, I know they're filling their bladder faster than normal. That's obvious. But the text also strongly emphasizes alpha blockers.
Yeah, and if we think about the mechanism there, alpha-1 receptors are heavily concentrated in the smooth muscle of the bladder neck and the internal sphincter.
Okay.
So if we give an alpha blocker to treat, say, hypertension, we are actively relaxing that sphincter. We are essentially unsealing the exit door.
Wow, okay, so we're causing the incontinence? That is a highly testable adverse effect.
Absolutely. Then you also have the other P for psychological or psychiatric factors and R for restricted mobility.
Right, like if severe osteoarthritis physically prevents a patient from walking to the bathroom in time, that's functional incontinence.
Exactly. Their urinary tract works perfectly fine, but the environmental and physical barriers are what cause the leak.
And finally, the S and IAPRS is for stool impaction. This one feels like a classic exam trap.
Oh, it is.
Because I'm picturing the anatomy right. The rectum sits directly palacious posterior to the bladder. So if a patient has a severely impacted rectal vault from chronic constipation, that hard stool mass just physically compresses the bladder neck and the urethra right against the pubic bone.
Yeah, it creates a pure mechanical outflow obstruction.
Yeah.
And if you don't perform a digital rectal exam or a really thorough abdominal exam, you will completely miss the diagnosis. You'll order urodynamics, and you'll get the question wrong.
Right. So once you have run through that checklist and you confidently rule out those transient reversible causes, then you move on to diagnosing the specific type of intrinsic incontinence.
This is where we categorize the issue into one of the big three: stress, urge, or overflow incontinence.
Let's apply our plumbing analogy here because it helps so much. Stress incontinence is a weak faucet valve. Urge incontinence is a spasming pipe, and overflow is a clogged drain that's causing a massive backup.
I like that.
So starting with the weak faucet valve, stress incontinence. This presents as involuntary leakage that's triggered by an abrupt increase in intra-abdominal pressure. So the patient coughs, they sneeze, they laugh, or lift something heavy, and that external pressure just overcomes the resting tone of the urethral sphincter.
Right, and the pathophysiology here usually involves urethral sphincter weakness, pelvic floor muscle weakness, or urethral hypermobility. On the MCCQE, you really need to pay close attention to the patient profile in the clinical vignette.
Who are we looking for?
You'll frequently see this in postmenopausal women due to that estrogen loss affecting the tissue tone that we just discussed, or in women who have had multiple vaginal deliveries, which can stretch and frankly damage the pelvic floor musculature.
What about men?
In men, the major red flag is a prior prostate surgery. A radical prostatectomy inherently carries a really high risk of damaging the external urethral sphincter, which leads directly to stress incontinence.
Got it. Okay, moving to urge incontinence, the spasming pipe. This is characterized by a sudden, overwhelming, compelling urge to urinate. The patient feels the signal and they simply cannot make it to the bathroom in time. Mechanistically, the detrusor muscle, the smooth muscle of the bladder wall, it's just contracting inappropriately during the filling phase.
Yeah, and while detrusor overactivity can be idiopathic, the exam will test your awareness of underlying neurologic disorders here. So think spinal cord injuries, multiple sclerosis, Parkinson's disease, or prior CVAs.
Because those disrupt the central inhibitory pathways, right?
Exactly. Normally, your brain suppresses the micturition reflex while the bladder fills. When those pathways are damaged, the bladder just becomes hypersensitive, it's poorly compliant, and it starts contracting at very low volumes.
Wow. Okay, and then the third category, overflow incontinence. This is where the clinical stakes escalate pretty dramatically. This is the clogged drain. The bladder becomes massively overdistended. I just imagine it stretches and stretches until the pressure inside finally exceeds the resistance of the blockage, resulting in this constant, continuous dribbling of urine.
Yeah, that's exactly what happens.
And this happens either because the bladder muscle can't contract properly, like in a hypotonic neurogenic bladder from severe diabetic neuropathy, or because there is a physical bladder outlet obstruction, like severe BPH in men, or advanced pelvic organ prolapse in women.
And of these three major types of incontinence we just covered, overflow incontinence and the severe urinary retention it stems from, it is the only one considered directly dangerous to the patient's physical health.
Right, because if the bladder cannot empty forward, that trapped fluid has literally nowhere to go but backward. The urinary pressure transmits retrograde straight up the ureters right into the kidneys.
And that back pressure causes bilateral hydronephrosis. It compresses the renal parenchyma, It leads to post-renal acute kidney injury. And if that obstruction isn't decompressed, it will progress to permanent, irreversible renal failure. It requires urgent intervention.
So, to distinguish these three clinically, the StatPearls texts detail a few diagnostic tools. They mention this cotton swab test for stress incontinence, where you insert a lubricated cotton swab into the urethra and ask the patient to perform a Valsalva maneuver.
Yeah, the Q-tip test.
Right. And if the angle of the swab changes by more than 30 degrees, it demonstrates urethral hypermobility. But I imagine we are more likely to be tested on less invasive, more practical tools on the exam, right?
Absolutely. The exam leans heavily toward the simple cough stress test and ultrasound imaging. So for the cough stress test, you just have the patient stand with a relatively full bladder, maybe around 200 milliliters of urine, and you ask them to cough forcefully. Directly observing immediate leakage is highly sensitive and specific for stress incontinence.
Okay. And for distinguishing urge from overflow, we rely on the post-void residual, or PVR, which we measure via quick bedside ultrasound. The physics of this are pretty straightforward. You ask the patient to empty their bladder completely, and then you immediately stand them to see what volume is left behind.
Simple enough?
Yeah. So if the PVR is greater than 200 milliliters, the bladder is clearly failing to empty, which locks in the diagnosis of urinary retention and overflow incontinence. But if the PVR is very low, say under 50 milliliters, the pump is working fine, which points you firmly toward urge or stress incontinence, depending on their actual symptoms.
Right. So let's assume the diagnostic workup. So a low PVR and a history of sudden compelling leaks, it points to urge incontinence. The MCCQE heavily tests the stepwise management of chronic conditions. You cannot simply jump to the most aggressive treatment.
It's like an escalator. The first step for urge incontinence must be behavioral therapy. Before writing a single prescription, you implement bladder training. You have the patient void on a rigid schedule, initially forcing them to hold their urine for an hour, and then gradually extending that interval to 3 or 4 hours.
Because you're literally retraining the brain-bladder neural connection.
Exactly. And you combine this with strict fluid management, eliminating dietary bladder irritants like caffeine, alcohol, artificial sweeteners, and initiating pelvic floor muscle training.
And the reason we enforce this non-pharmacologic first step is because the second-line medications, they carry a pretty heavy side effect burden.
Tell me about it.
The traditional second-line drugs are antimuscarinic agents, so medications like oxybutynin, tolterodine, or sulfonacin. They work by blocking acetylcholine receptors on the detrusor muscle, which effectively decreases its ability to contract.
But acetylcholine receptors aren't only in the bladder. By blocking them systemically, you induce the classic anticholinergic side effects, right? Dry mouth, blurred vision, tachycardia, and severe constipation.
Yep.
And if we think about the physiology of the blood-brain barrier, some of these lipophilic drugs, especially oxybutynin, they can cross right into the central nervous system. They block the central cholinergic pathways that are absolutely vital for memory and cognition.
And this right here is one of the highest yield traps on the entire exam. You must be hypervigilant when considering antimuscarinics in the elderly population.
Okay, why specifically the elderly?
Because if you give an anticholinergic to an elderly patient, particularly one with mild cognitive impairment or early dementia, you can drastically worsen their cognitive baseline. You can actually precipitate an acute hyperactive delirium or seemingly accelerate their dementia overnight.
Oh, wow. So if the clinical vignette presents an 82-year-old with mild Alzheimer's and urge incontinence, oxybutynin is the instant fail option.
Instant fail.
Okay, so to treat the bladder without destroying their cognition, we have to use a totally different mechanism. And that brings us to the beta-3 adrenergic receptor agonists like mirabegron. Instead of trying to paralyze the muscle contraction by blocking acetylcholine, a beta-3 agonist actively stimulates the sympathetic receptors on the detrusor, which promotes muscle relaxation during the filling phase. It completely bypasses the cholinergic system and avoids that cognitive wipeout.
Exactly. Now, you do have to monitor their blood pressure, as beta-3 agonists can induce hypertension, but they are vastly safer for the aging brain.
Good to know.
And if medications fail or are just poorly tolerated, then we move to the top of the escalator, which is third-line neuromodulation. This involves percutaneous tibial nerve stimulation, or PTNS, sacral nerve stimulators, or even injecting Botox directly into the detrusor muscle to cause localized temporary paralysis of those spasms.
Wow.
Yeah, and in that elderly dementia patient, you might even bypass oral medications entirely and move straight to something localized like PTNS, just to completely avoid those systemic effects.
Makes a lot of sense. So we've seen how dangerous it is when an enlarged prostate or a prolapse acts like a clogged drain, forcing pressure backward to the kidneys in adults.
Mhm.
But that exact same back pressure emergency can happen in a newborn.
Yeah, it can.
Not from a clog, but from a faulty valve. So we are shifting focus now to the upper urinary tract to tackle vesicoureteral reflux, or VUR.
VUR is defined as the abnormal retrograde flow of urine from the bladder up into the ureters and renal pelvis. And it typically occurs during voiding, which is when the intravesical pressure, the pressure inside the bladder, reaches its absolute peak.
The anatomical defect here is so fascinating. Normally, where the ureter enters the bladder, the ureter-vesical junction, or UVJ, it doesn't just poke straight through the wall. It actually tunnels obliquely through the bladder wall musculature for a short distance before opening into the lumen. I picture this like a flap valve on a scuba snorkel. As the bladder fills and the pressure rises, the bladder wall stretches and actively compresses that submucosal tunnel, pitching it shut and creating a watertight one-way valve. But in VUR, that intramural tunnel is congenitally too short. The flap valve just fails.
And because that anatomical tunnel lacks sufficient lengths, it can't compress against the rising pressure. So when the detrusor contracts to push urine out the urethra, a significant volume of that urine just shoots the wrong way right back up the ureter.
Bakes.
Yeah. VUR is actually the most prevalent urological abnormality in neonates. It's present in about 1% of all newborns. And if a fetus is flagged for prenatal hydronephrosis on a maternal ultrasound, the incidence of underlying VUR jumps to 15%.
Wow, okay.
Postnatally, it most commonly presents as a young child with recurrent febrile urinary tract infections.
And the danger of this retrograde flow really comes down to the water hammer effect. When infected urine from the bladder is violently refluxed under high voiding pressure up into the renal pelvis, it doesn't stop at the surface. That pressure forces the infected fluid deep into the renal papillae and the collecting ducts, a process known as intrarenal reflux,
Right.
which triggers a massive localized inflammatory response.
And that intense inflammation causes pyelonephritis, which then heals by forming permanent renal cortical scars. Repeated scarring events destroy functional nephrons, eventually leading to renin-mediated pediatric hypertension and progressive end-stage kidney disease. VUR-induced reflex nephropathy is responsible for roughly 5% of all pediatric renal transplants. It's really a slow structural destruction of the kidney.
That's heartbreaking. So knowing this is a congenital structural defect that carries such high stakes, the exam often tests the screening protocols for family members, right? If I diagnose a child with VUR, the parents are immediately going to ask about their other kids.
Oh, for sure.
The data shows siblings have a high incidence of sharing the defect, between 27% and 46%. But screening isn't just a blanket rule for everyone. Age is the determining factor here.
Yes. For siblings under the age of 3, the risk of undetected VUR causing permanent renal damage before they are old enough to articulate symptoms, it's very high. So a baseline renal ultrasound is strongly recommended for this age group.
Okay, what about older kids?
However, for older siblings who are already toilet-trained, completely asymptomatic, and have no history of UTIs, routine screening is considered optional. The critical window for primary renal scarring generally occurs in the first few years of life.
Okay, so let's talk about diagnosing the primary patient. A child is brought into the emergency department with their first febrile UTI. The initial imaging evaluation is always a renal ultrasound because it's non-invasive and spares the child from ionizing radiation.
Right.
But an ultrasound only shows a static anatomy. It can show us a dilated renal pelvis, sure, but it can't dynamically prove that urine is actively flowing backwards.
Therefore, if that initial ultrasound shows abnormalities like hydronephrosis or existing cortical scarring, or, importantly, if the child subsequently develops a second febrile UTI, you must escalate to the gold standard diagnostic test, which is the voiding cystourethrogram, or VCUG.
The mechanics of the VCUG are vital to understand. You literally have to catheterize the child, fill their bladder with a liquid fluoroscopic contrast dye, and then remove the catheter and capture continuous X-ray images while the child actually urinates. You are watching in real time to see if the contrast dye shoots backward up the ureters against the flow of gravity.
Yeah, and the VCUG allows us to officially grade the severity of the reflux on a scale from Roman numeral I to V. Grade I is mild. The contrast only reflexes into a non-dilated ureter.
And grade V.
By the time you reach grade V, you are seeing massive high-pressure reflux causing severe dilation and tortuosity of the entire ureter, along with severe blunting of the delicate renal calyces. And the grade you identify in that VCUG is the primary driver of the entire management plan.
Because the management approach is, well, it's a delicate balance. 70 to 80% of children with low-grade VUR, so grades of Thurston 2, they'll actually experience spontaneous resolution by age 5.
Yeah, they outgrow it.
Yeah. As the child grows, the bladder wall thickens and that short intramural tunnel naturally elongates, eventually fixing the valve on its own. So for those patients, we aren't rushing to the operating room. We rely on medical management, specifically continuous antibiotic prophylaxis, or CAP, just to keep the urine sterile while we wait for their anatomy to catch up.
But the choice of antibiotic requires caution. For neonates under 2 months of age, we rely on amoxicillin. You absolutely have to avoid drugs like trimethoprim sulfamethoxazole or nitrofurantoin in that specific neonatal window,
Why is that?
because they interfere with bilirubin metabolism and can precipitate kernicterus. But once the infant is older, those drugs become the standard agents for CAP.
Okay. However, the guidelines around CAP are shifting pretty rapidly. Putting a child on a daily prophylactic antibiotic for years is highly controversial now. We are having to weigh the protection of the kidney against the guarantee of altering the child's developing microbiome and, contributing to global bacterial antibiotic resistance.
Right, it's a huge issue.
We just don't prescribe it as freely as we used to for low-grade reflux. But for the severe cases, grades the Thurvi and V, the calculus changes entirely.
Yeah, if a patient has high-grade reflux, or if they fall into a high-risk category such as uncircumcised males or children with underlying bowel and bladder dysfunction, their risk of permanent renal scarring is exponentially higher. And if a child on prophylactic antibiotics suffers a breakthrough febrile UTI, well, medical management has failed. We must intervene surgically to mechanically recreate that protective valve.
And the surgical interventions aren't just about tying off a tube. They require precise anatomical reconstruction. One option is endoscopic injection. A surgeon uses a cystoscope to inject a bulking agent. It's a gel made of dextranomer hyaluronic acid directly into the submucosa right under the ureteral orifice.
Interesting.
Yeah, this creates a small artificial mound that acts as a physical backstop, mimicking the flap valve to prevent reflux. It's minimally invasive, often referred to as the STING or double HIT method.
And that endoscopic approach is excellent for intermediate grades, but for the most severe grade 4 and V cases, the anatomical distortion is just too great for a simple gel injection. We actually have to perform a formal ureteral reimplantation, which can be done via open surgery or robotic-assisted laparoscopy.
And instead of just naming the techniques on the exam like the Lich Grégoire, let's look at what the surgeon is actually doing. They literally have to detach the ureter from its original faulty insertion point. Yeah. They then surgically tunnel the ureter through the bladder musculature for a much longer distance before opening it into the bladder. They are manually recreating a 5-to-1 ratio of tunnel length to ureter diameter. They are rebuilding the anti-reflux valve from scratch.
Yep.
And the success rates of these reimplantation procedures are exceptionally high, usually above 95%.
Incredible. So just to synthesize this for exam day, you must remain vigilant on both ends of the age spectrum. In the adult presenting with a leaking bladder, do not jump to urodynamics or prescriptions before ruling out the diaper's reversible causes. Differentiate stress, urge, and overflow presentations based on their physical triggers and post-void residual volumes. And above all, do not fall into the trap of giving an elderly patient with cognitive impairment an anticholinergic medication for urge incontinence.
Yes, and in the pediatric population, recognize that vesicoureteral reflux is a structural plumbing issue that threatens the very survival of the renal parenchyma via the water hammer effect. Use renal ultrasound as your initial non-invasive step, but rely on the VCUG to dynamically grade the reflux. Balance the use of antibiotic prophylaxis against the risks of bacterial resistance, and reserve surgical reimplantation for those high-grade or recurrent cases to permanently reconstruct the valve and prevent irreversible scarring.
It really all connects back to understanding the pressures, the muscular anatomy, and just the fundamental physics of the urinary tract.
It does. But before we sign off, there is one final, pretty provocative thought buried in the source text regarding the true etiology of urge incontinence. We are historically taught that urine in the bladder is completely sterile unless there is an active symptomatic infection.
Right, that's the classic teaching.
But recent microbiome mapping research suggests that a subtle alteration in the urinary bladder microbiome might actually directly trigger detrusor overactivity.
Really, it completely challenges the fundamental dogma of urology. If bladder hypersensitivity and involuntary muscle spasms are actually tied to a dysbiosis of local bacterial flora, it raises an incredible question about the future of management.
Yeah.
What if the next generation of treatments for overactive bladders isn't about prescribing antimuscarinic muscle relaxants or implanting electrical nerve stimulators?
Yeah.
What if it's about prescribing targeted probiotics to restore a healthy gut-bladder axis?
A probiotic to cure incontinence. I mean, it completely reframes the spasming pipe metaphor we use today. Instead of using heavy medications to force the pipe to relax, we might just need to fix the microscopic ecosystem living inside the plumbing.
Exactly.
It is such a fascinating concept to mull over as you continue your studies. Thank you for joining us on this deep dive. Best of luck on your MCCQE preparation. Remember to trust your training, keep thinking critically about the mechanisms behind the symptoms, and we will see you next time.